Thanks, Frank and Sienna. Thank you for having me. How are you guys doing? Good? Okay, let me just get a feel of where everyone is and what years are you in? Are presuming you all are bio majors? Going into medical? No, not necessarily?
I'm a clinical psychology major.
Okay, cool. Awesome. We'll need more of that for sure. You won't have any problems looking for jobs for sure. How many is in their first year? Good. All right. Second year? Third year? Okay. Fourth year? Okay. Good. All right. Nice mix. And sorry, pardon me, I overheard you're from Alaska. That's really cool. I got to visit Alaska. It was a beautiful state. Anyone else from out of state, from somewhere else being here? Mostly? Where are you from? Nice. And? Florida. I've been there. I've been there. Both good, but I like California. San Diego. Really nice. It's hard to beat here. Okay. Just for a general idea, I'm in psychiatry. And anyone know the difference, psychiatry, psychology? I hope. Okay, good. If you don't, I can explain it, no problem. And my hope is to just answer general questions, any questions you have, either the path from undergrad to med school to psychiatry. That's one on academic path. Two is maybe common topics in psychiatry that I come across that maybe you have questions about. Maybe you have friends and family members that you're curious about in their diagnoses and you're wondering what's going on here? How do I help this person? What is the problem they're struggling with here? What are some common things you see in college that, among your age group that you're wondering, how can I help this person? Or I think there's something going on with me and I don't know where to start. Student health right here. I have a lot of friends that work in that department and they've helped a lot of students over the years. I graduated from the residency program at UCSD as well. So, we see a lot of all the stuff going on around here. Okay, so let me just open up to the floor. Any questions you have that you'd like me to answer or keep in mind over the next 2 hours? And any topics, whether it's depression, anxiety, PTSD, substance use, ADHD, or relationship stuff, or just academic path to getting from undergrad to med school to psychiatry kind of deal. So just throw it out, give me some ideas so I know. Academic? Sure, okay. And I saw another hand.
Like how you like what you did in undergrad and like what maybe like the courses you took, like what steps you took to like get into med school.
Sure, okay. Undergrad to med school to residency, okay.
Maybe like how to get more involved in research.
Sure, okay. Specifically in mental health, I presume?
Yeah.
Okay, yes.
Your extracurriculars.
Okay. And I saw another hand there.
Why psychiatry?
Why psychiatry versus anything else in medicine?
Yeah, like your first thought process.
Okay, great question. Thank you for asking that. I'd love to talk about that. Yes.
Maybe like tips and advice for like resume stuff.
Okay, resume tips. Sure, let's put it here. A lot of preparing here. I see. You guys are very future oriented. Yes.
I guess like day in a life of what psychiatry looks like.
I like. Okay. Do we have any backup of these? You guys might not see very well. Okay. Day in the life of a psychiatrist. All right. Okay. Anything else? Anyone else? Yes. Good. Motivation, maintenance. That's a great question. You got it right. It's really messy like a doctor too. Yes.
Work-life balance.
Work-life balance. Got to have that. Everyone asks that these days. Okay.
Just knowing what to set when ADHD can mask like anxiety.
So ADHD versus something else, kind of like. How about we go with maybe general diagnostic features? If we have time to squeeze it all in, okay? All right, I can squeeze it in. I saw one more hand down there. Yes, two. Okay, go first.
How did you kind of like handle your finances through med school?
You borrow, unless you have rich parents. Okay, and the pros and cons of psychiatry. Okay. I can't see any cons, or else I'd be out of it by now already.
I guess it kind of goes with pros and cons, but like maybe share like your favorite experiences as being a psychiatrist and also
Okay.
the hardest hardest challenges?
Yes, fave experiences and hardest challenges. Okay, this will definitely get us all through the 2 hours here. All right, I saw another hand. Yeah.
Like the intake process when you have a new patient.
Okay, I like that. We call it the H&P, history and physical. Yes.
Not just why psychiatry, but also the specialty.
The subspecialty of psychiatry,
Yeah,
like there's child psychiatry, there's forensic psychiatry, there's like adult psychiatry, geriatric. I mean, right? Okay. Why psychiatry and all these subspecialties? Okay, we got child, we got adult, we got forensic, we got geriatric.
Which one are you?
I am adult, but I kind of lean into there because I just have to deal with a lot of that. I wish I was doing this because it's super fun, but it's a very different route. I don't like that because I feel like I need to solve problems, not to cause more problems. So, yes.
What are some qualities or characteristics that you developed over your journey that helps you like be successful how you are now?
I like. Okay, the journey, the growth, and the specifics. Does that sound? Maybe? Okay, specific characters? All right, I love it. Such a great question. I don't think I asked these questions when I was an undergrad. I did not know anything about med school and undergrad. I just knew my friends were saying they're applying to med school, so I applied to med school. And I was in med school was when I realized, oh, third year and fourth year is when I do like clerical, and then there's a residency after that. I had no idea. No idea. I just did it because everyone else did it. It was terrible. It was terrible, but thank God it worked out. Okay. A little bit about me. I was born and raised in Vietnam. I came here when I was 10 with my family. So my family, we were lucky. We were sponsored by my uncle who came here in 75. And so our family, by political refugee terms, could be sponsored to come over, but we went safely. We didn't have to escape through the boat. We just flew all the way from Vietnam through Thailand to Philippines and here. Lived in Southern Cal for all my life until I did UCI for undergrad. Then I went to Florida for a master's. And then I went to Missouri for my first 2 years of medical school. Then I went to Arizona for my third and fourth year of medical school because that's just how the school did it. And then I joined the Navy during the medical school and served in San Diego for my 5 years. First year of internship and 4 years of serving active duty, being deployed as a Navy doctor, borrowed by the Marines on a ship into the Middle East. And I learned a lot of life and experience in leadership. I did all that, and then I came back to UCSD and did my residency in psychiatry. And I did psychiatry in, my 1 year of internship, my 4 years of Navy payback, and then my 3 years of PGY 2, 3, and 4. PGY is postgraduate year. That means when you're in residency. PGY 2, 3, and 4 in UCSD. I got out, then I served the Navy as a civilian. I was still working for the military, but I wanted to work as a civilian, so I didn't have to be deployed and all that stuff, but I still helped a lot of my military guys because I loved working with the PTSD military population. These were the guys that went to combat, and they were never quite the same coming home. And you ask why I chose psychiatry and, what really motivated me to do that? It was in my work as a general doctor and seeing this poor 19-year-old kid coming back from Iraq, and he was broken in pieces. I mean, he witnessed his buddy being blown up to pieces, and he was asked to collect all his buddy's body parts. Okay, so you're blown up, and your boots are here, gloves are there, helmet's there. He gathered it all up, and he brought it back respectfully for this guy's family. And the thing he had asked to come to see me was, I can't get the image of my friend's boot out of my head. It's just one boot, blown up. It's all here. And he sat there, and his whole life in front of him was just not going to go well because he just could not move on to be this tough Marine. He thought he was going to go out and do some tough stuff, and he was really hurt. And his life was, thank you so much, and his life was pretty much stopped because of that traumatic experience. And I think at that moment was one of my most critical moments in medical history of my career was I'd like to help a person in that state of suffering. I loved surgery, and I loved ER because I could like multitask and do 10 ER rooms at the same time. And my surgeon attending really liked the way I sutured all my patients up when he taught me. He was like, you're going to close up every single patient after I finish with all the appendectomies. And I got really good, and I really enjoyed that during my medical school years. And I thought I was going to be a surgeon, but when I sat with that Marine, it changed my course. It was like, this is what I want to do. I want to fix what's up here. So I worked with the Navy for 5-6 years as being the psychiatrist for a comprehensive center that helps guys coming back from combat and aren't doing well. And we take them in and we just fix the trauma part, and we fix the substance use part, and we fix the relationship part, right? Because a lot of them come back and they just don't know how to reintegrate in a normal process. I mean, you're going from day-to-day death of do or die kind of decision to now just overwhelmed with the civilian stuff and the kind of things that we all kind of worry about on a daily basis. And they just could not relate. Some kids here at the same age were worrying about, did you watch American Idol? And some were like, worrying about like what to wear to a party. And here was a guy that lost his buddy, right? And he's in that space of pain. And so it's hard to relate when you come back after such an experience. And my work I found it really meaningful to give that sense of life and purpose again to such a person who is so hurt. I did that, and then the VA, you know the difference between active duty and veterans? Active duty is when you're still serving in the military, when you're still wearing the uniform. A veteran is after you got out of the military. You're now after service, right? And you still get the military care, the health care, but it's in the civilian context. So the VA wanted to do the same, of creating a comprehensive program of treating psychiatry, providing psychology, spirituality, and housing, and jobs, giving these guys jobs again, and fixing the relationship. So now I'm currently the medical director of that, right? 40-bed unit, and I've been there the longest out of my whole life of all the jobs I've had. If you think about your academic career, you're like 4 to 5 years undergrad, and then maybe a gap year, and maybe 4 to 5 years of medical school, hopefully 4, right? But some people take a gap year to do research, and then another 4 to 5 years to do residency, right? And then after that, it'll be your first job. Where do you work? Which hospital? How long? And do you like it? Does this match your specialty? Do you like the coworkers, right? And that was my transition. It was always like a 2 to 4 year at each place. Navy was longest for a little bit at 5, and now I've been at the VA for 8. So add all that up, talk about all the experience and the journey and the growth along the way. You never know how life comes at you with the stuff to teach you. And I guess one of the things I would say is sometimes you just don't wait till all the things to be completed to do the next things. What I mean by that is a lot of people feel like, let me wait until I'm 35, I'm done with residency, then I'll start having a family. Medicine is really tough. And if you're waiting until you're 35 to have a family, that's like, maybe you'll be 40 when you have your couple of kids, and now you're in your 60s when your kids are barely teenagers, right? So one of those things is like, sometimes just plan to do life along with all the academic stuff and figure it out as you go, okay? Don't wait for one thing at a time in a sequence. You'll never get to do all that. So just remember that the timeline of medicine is very, very demanding. So that's broad overall stroke of a timeline of my life up to now. Let me tie this in how psychiatry works from undergrad to, so you got your 4 years, and in here, of course, is where your psych research, if you're interested, and then your clinical volunteer is, where you want to see. Is this what I want to do? How do I create these opportunities? I was at a health fair yesterday in Orange County. Did anyone down here know there was an Orange County health fair? And did you know there was a psychiatry service up there, right? If you did, you could have volunteered and then see some of the patients I saw and do that. So look for those kind of things to align. I would love to have you guys shadow me, but I work for the VA, so all the layers of how to get into that building is very tough. If I had a private practice, I'd say, come on over. That would be one opportunity. Look for private practitioners that are willing to take you in to shadow, but in the realistic and honest mindset, when they take you in, you're slowing them down, right? They're seeing like 10 patients And then now they got to sit down and explain to you and all the stuff that they're doing if they are kind and generous with their time to do all that. So make sure you do a good job of making it easier for them so that they would want to do that. Can I help you with some kind of stuff? How can I be of service to you so that you would want me and allow me to be the fly in the wall in the shadow and observe kind of thing, okay? Just always think proactively, how can I make it easier for you so that you would allow me to be in that space that you are, seeing a very intimate moment of a doctor and a patient talking about a very sensitive subject. So research, clinical, and church, of all places. I found my growing place as like a person in being in a church community. But what I didn't realize was all those years of being a friend and being just a person that friends trusted to come and talk to, I was learning how to listen to people. I didn't know that was something that was in me naturally, but I was listening to my friends and I discussed these things and I was just a concerned friend. But it turned me into hearing better and then knowing how peers of our age are going through very similar stuff. Relationship stuff, you're stepping into the world, you're trying to do academic, but you're also growing and then you're finding connections. So all these little life problems are not so little, struggles at home, struggles at school, and trying to fit it all into a 24-hour time span and having that opportunity to be a friend to listen, that helped me personally. So find your niche of how you can be that listener, that basically support for the friend, and that kind of grows. If it comes naturally to you, you're more than likely ready to take that, that path, right? And it doesn't mean it can't be taught either. So, a lot of the things we learn along the way, even when I was going through 4 years of residency, I still felt like there was not enough teaching. And they taught me so much. I was so tired of learning. It's still not enough. You still have to do more to learn more. I said earlier, psychiatry is 4 years of medical school, 4 years of residency. Their intent is to make you a prescription person in today's medicine. You are a prescriber, right? They make more money off of you. They, as in the insurance world, in your own world, as you've put 8 years of your life. And now I think the price tag is 500,000 plus to get a medical degree, if not more. My days 20 years ago, about 200,000, 500,000 plus interest, you're looking at paying that over 30 years, right? As you're starting out as a doctor and you're paying every year all the monthly payments of student loans and all that, it's about 1 million in the end over 30 years. So you got to find a job that can have some kind of negotiation where they'll say like, if you work for us, we'll pay off your student loan. Some public health programs, some will say like, we can't get a doctor to come out to Indian reservations. If you come out there, we'll wipe out your loan. But the contract is you got to stay with us for 5, something like that. So know the financial cost going into this endeavor, right? And that's with any specialty. You're going to lose about 500 to get through med school. And then you live like a poor student through the years of residency as well. So it is not for the faint of heart and not for those who are looking to get rich quick. There's many other ways to get rich quick. This is not it, okay? I got sidetracked. Where was I going with that? Residency, clinical research. Okay, let's go with, these are the undergrad years. The med school years, the first 2 are more didactic. And the second 2 are more practical, right? So these 2 years are gruesome, but the people who thrive as a book learner, they'll do well. It's just gross anatomy, science, biochem, OChem, molecular chem, physiology, just pounding into you at a deeper level. Now it's clinical. You learn gross anatomy. They don't just remember where the body parts are. You got to remember what happens when that body part has an issue. There's a nerve problem. There's a vessel problem. There's something going on. How does that look like in the real world when this nerve is damaged? And you start to learn and integrate medical conditions into it. Pretty cool. The fun thing is when you learn these first 2 years, whatever medical diagnosis you read, you think you have. We tend to joke like, it's like you keep reading all these problems. It's like, I think I have that. Do I have that? So it's like everyone turns into a hypochondriac in these 2 years. These 2 years, you're following a whole team. You're like bottom of the food chain in terms of a clinical team going out and seeing patients, right? You're going to rotate through all the breadths of medicine, especially family med, internal medicine, CCU, ICU, ER, surgery, pediatrics, and emergency ER. And you get to elect some of the things that you like as well, right? So the third year is pretty prescribed. The fourth year is more of a loose selective so that you can pick what you want. And they expect with just 1 month of each of these rotations for you to like know for life that this is the field you're going to go into, right? So if you had like a good rotation and a good attending and a good experience in anesthesia, and you're like, I'm going to go to anesthesia, right? And then you put all the time and effort into doing anesthesia. And I see some of my friends coming out of anesthesia. I'm saying, it's not what I want. It was good for 1 month, but not for a whole life. Shoot, 500 into med school, 4 years of residency, now doing anesthesia, and it's like, crap, I don't like it as much. So it's okay to not rush, know yourself, get some time, learn and ask and do everything that you can to really know what kind of doctor you are so that you can be really happy even on the tough days that you have. Because even in the job that you like, you will have the tough days that you'll have to struggle through and make sure you can, have the capacity to do that. All right, so undergrad, med school, and you finally match. You like spend a lot of time here hoping somebody in the residency program takes you in your PGY1, okay? Stressful year. More of the bottom of the food chain stuff. This one, they tell you to go collect all the labs, all the vitals, rounding, patients, and everything, and you collect all that information. You report to the junior resident and you report to the senior resident, and then the senior resident then talks to the attending, and the attending teaches the group by asking questions like, so what's the most common cause of hyponatremia in this patient, right? And they'll go in order of things. And this is when it's stressful because it's like, man, I had to stay up. I did 12-hour rotation. I still got to go home and read all this stuff. And I go and present. They're going to ask me, and I better know, or else it's going to look pretty embarrassing. I don't know. And then people get stressed out and all that because they're publicly shamed. We hope we don't have a lot more of that going on, but there is some school program that it's just the way that they learn. It's like, we're going to ask you questions. We're going to put you in front and center. You better know your stuff. So PGY1, you learn all the monthly rotations of, the basics of medicine, right? Pediatrics, OB, family med, internal med, ICU, ER, surgery. And you just got to be this house officer, right? And all the basics of like at least what to do to not kill the person, all right? Know when you have to ask for help and how you do the basics like, oh, patient can't sleep, what do I do? Okay, just give 2 of the sleeping pills. Or patient's hurting, okay, give me 2 Tylenols, that's fine. But sometimes it's not just the pain, there's something going on and you gotta figure it out, and then you gotta work it up to the senior resident to kind of man this person. But you are the first person in charge in that hospital on call overnight. It's a scary feeling when you have the cell phone, the duty cell phone, and they call you. It's like, I have to make the decision, right? PGY2 in psychiatry is fun. This is the inpatient year for me. This is kind of like, the breadth of all that stuff. PGY2 is more psych specific. I'm maybe 6 months, I'm in the inpatient side when a patient presents in the ER and we see that this person has a reason to be admitted to the psych unit, and you do the H&P on the psych patient. You ask them why you're here. What brings you here? I'm hearing voices, or I'm high on all my meth and I just need to crash, or, I don't want to live anymore, right? That we have plenty of those, right? That's our field. That's what we do. They don't have hope. And you're trying to stabilize that person and give them a sense of hope and a sense of future, and so that the decision that they just had yesterday was, there's nothing else better than just end my life. I do not see it beyond this choice, right? And the work is about to expand options and opportunities and stabilize, right? So that's the fun part of the inpatient side. And from my own training program, I did child psych for a month during that rotation, and I did substance use during that second year. So you learn a lot of like when a person has to go through rehab and they have to kind of like come out of detox and go into recovery and all the challenges of recovery. Does anyone have a friend or family member or someone they know that is addicted to a substance that is still struggling with, right? Very common in psychiatry. You can't go into psychiatry and not come across a person that struggles with substance use. So you got to learn what is the life course of a person that gets into addiction and what keeps them in the addiction cycle and what can we get them to be out of the addiction cycle, right? That's the journey. At least we hope, so that they don't just stay here, right? PGY3 is your outpatient year, okay? You're now kind of like more on your own. You're seeing a doctor, you're the doctor that the patient is seeing on a regular basis, on a monthly basis. I'm sleeping okay, I'm eating okay, or no, I'm still hearing the voices, it's not going down, I'm not doing well. And you have to decide, do I still give meds and change the regimen and I can follow up with this person in a month? Or do I think this person right now, right here, needs to go to the inpatient ward? And I gotta make that decision while I have 7 more patients on my caseload today. How do I balance and do all that? You learn to be an adult doctor making tough decisions all at once, right? And so the years of being on call here, the years of working long hours here, kind of toughened you up to know how to make difficult decisions by the time you get here. Oh, by the way, I still got to live my life and have my friends and see my family and have everything else going on. I'm not just a robot and a doctor and, you know, not living life. So remember all the other stuff, but this is a part of you as well, okay? PGY4, you're basically on your own kind of being a senior resident. Now you lead all these other junior residents of how to make those decisions. Now you learn how to be a leader, to be just right after this, you're the attending. The buck stops here. Any decisions that you make that doesn't look consistent with the hospital policy, whew, that's a hot seat. You got to answer to a lot of questions, right? And did you do this? Did you do that? And then you just have a lot of self-doubt and a lot of concern. I don't want to make it all scary, but that's just kind of like the stressful side of medicine. So know what you're going into, and a lot of people don't realize that there's this journey that you have to have this grit, resiliency, and the bouncing back, the flexibility, right? The inflexibility and the rigidness and the kind of like stress kind of state of living, it's not healthy. We do have a lot of residents and doctors that don't do well. And they struggle just like anyone else in any other kind of stressful jobs. They do resort to, you know, non-positive coping mechanisms, okay, just like anyone else, and they struggle. And we got to put them into programs that help them to recover so that they can be doctors again, or at least just be another human being before, you know. So a lot of struggles along the way. Don't want to make it all scary, but that is the journey, and you learn to be a leader here, learn to guide all the junior residents, and learn to be the attending. And then your life, you get to choose, right? What fits me, right? There's child psych, and child psych is an extra year. There's like by 3rd year right here, you would go to child psych and you would do extra years. So you'll probably be PGY5 to get the child psych. And child psych is fun. You know, it's treating the child, but you're also treating the parents, because a lot of the problematic family circumstance stem from the parents having difficulties that translates into the child's experience. And now you're looking at the parents who are saying like, fix my child. I'm like, hold on. Let's talk about how the child got there. What are you doing, right? You're screaming at your kid, but if that's your role modeling of how to do the work, how do you expect your kid not to scream, right? So learn to know. And so it's a really fun job in the sense of the whole family unit. Adult psychiatry, that's the most popular because everyone just goes down that route. Me, I had the military background, so I love working with the military population. I'm also now doing a private practice on the side to see just general non-military population. The thing about me, I'm fluent in Vietnamese, so I want to help my Vietnamese community. Vietnamese and Asians in general don't like to talk about psychiatry. You know, we don't have a mental health problem, right? We're all okay, right? And so it takes a lot to be vulnerable and be okay with saying, I'm struggling. I'm struggling with depression and anxiety. It's very hard for an Asian person to say that in those exact words. It's usually my back hurts, my headache, I can't eat, my stomach hurts, somatic symptoms coming in, I can't sleep. That's the most common. But when you start talking and you peel out the layers, why aren't you sleeping? Oh, I'm worried. What are you worried about? My kid. What about your kid? This, that, and then, poof, it's the whole story. And then you got your forensics. This is if you like sitting in the hot seat and you like to play with lawyers, that's a fun one, okay? The opposing side lawyers likes to make you look like a fool, right? To discredit you. And your side is trying to build up the case from a medical standpoint that why the patient deserves such, breaks from the court, or why you need to prosecute and put this person away because it's a dangerous person, right? So it's a very dark, in a way, job, but it appeals to some people who enjoy that kind of like verbal jujitsu with the lawyers and the judges and the demographics that they work with, okay? You're dealing with, what's a good movie to show that to? Primal Fear. It's an old movie with Richard Gere, Edward Norton. Anyone know about that one? It's a good psychological one if you want to watch. Primal Fear. And then geriatric. It's tough being old in this country. We focus a lot on youth and beauty and energy and young and fun. When was the last time we had an open forum with a lot of knowledge that goes into what is it like to be in your 70s in this country without a whole lot of help if your family's all scattered? 70 in a country that like takes aunts, uncles, nephews, cousins, and nieces to just everybody helping grandma is a different story than grandma being isolated here. And aunts, niece, uncle, nephews are all working. They're all scattered. Grandma is sitting at home 24/7, right? And then grandma needs to go into nursing home. And then how the mental health deterioration along that just natural aging stage. And you, as the geriatric doctor, geriatric just means elderly, geriatric psychiatry, aged, for the aged. And you deal with memory loss. You deal with complicated medical problems that as your body ages into the 70s, your heart gives out, your liver gives out, your kidney gives out, your brain is not there, right? And you still want to bring quality of life to this person, bring dignity to the end. And a lot of people resonate with that. They have family members that, kind of motivated them to be in medicine in the first place because of my grandma and grandpa had this experience that, make me want to help my other people of similar state. So it comes from a personal story of why you care for being there, okay? All right. I don't think they teach this enough. And oh, by the way, can you guys do me a favor? Subscribe to my YouTube. You'll learn a lot on there, okay? And you'll see some of this again. It's called, if you search this is Dr. Lou in Vietnamese, or you can search this way and you'll find it. Okay. On there, one of the video talks about the 4 agreements, okay? I love teaching this because it applies to life at any age. Even my adult friends who are in their 40s and 50s are struggling with this. Whenever you're working in a complex system medical school, right? You're working in here even. Like you have to do group projects. You have to deal with your family unit. You have to deal with people that you're just going to have to constantly work in groups. And working in groups mean working with people you may not agree with, but you still got to save this person's life. How do you do that in a system and maintain your sanity? What is the ground rule that will keep you as a productive, effective doctor, right? I like to use my 4 agreements whenever I come into conflict, okay? Be impeccable with my word. Say what I mean what I say, all right? So that you have to be very mindful of everything that comes out of you has intent and purpose. You don't just say unnecessarily, and it also goes for you. Something like the author would say, don't say oh my God, that was so stupid of me, right? That is actually an injury to yourself to disrespect your own intelligence. And so be impeccable with your word in saying what you mean to the person that you're having a present moment in talking to. Really focus on what comes out. Only quality words. Don't make assumptions. We've heard enough of that, right? What do we do when we assume? You make an ass out of you and me, right? So we don't do that. One of the best ways to do that is to practice saying back what the other person just said. Don't do anything else. You say, what I think you just said was, what I heard you just said was, repeat. Are they listening? Are you listening? Did you say exactly what did they just say, right? It's a good trick. It's simple, but it connects you to the person and it helps you to be out of the assumptive state and into the clarifying and active listening state, okay? People love it. You'll get people's attention if you say, I think I heard you said, am I correct? And then you can go on to clarify the point. Don't take things personal. You know how people are just triggering and they really irk you and they get under your skin and you just want to go after them and you want to take it personal and you're like, you hurt me verbally and you like did all this thing to me. I'm going to get back at you. I'm going to wait until the day. I'm going to get back at you and then you're going to feel it because I was hurt, right? Taking it really personal, right? Apologize for that. So don't take it personal is allowing for yourself to say, the person that just did that to me is going through a phase of growing in themselves. And this is a reflection of who they are. It is not a reflection of who I am. I leave that to them to deal with. It's water off a duck's back. I work on myself. I have zero control over any of you. Zero, right? I can have some sense of influence by how I conduct myself so that I can be of influence to you, right? Do you want to listen to me in this room? Are you listening to me? How am I doing that? Am I building trust? Am I building a sense of competence? Am I building a sense of like, I have some expertise that you can listen to? That's my influence. I don't tell you like, listen to me, come on, like, pay attention, right? None of that works, right? It's just how I project what I have, and it's up to you if you choose to listen or not, right? I don't take it personal if some of you are doing whatever you're doing. That's you, right? But to me, this is what my time is in the present moment, what I can offer, up to you, how you want to take it. Always do your best, okay? This is on a day you're like sick as a dog, doing your best is just get some rest, right? Get better, feel better, right? On a day where you're super healthy and you have 100% battery charge, there's more expected of you. Get your shit done, right? Go out and help people do all that stuff, learn, grow, right? So have this sense of expectation of yourself to do your best in being impeccable with your word, in making no assumption, in not taking personal, and continue to strive. That's just basic human growth and development that you're asking, because these things will help add to your work-life balance. Why? Because you're not stressed out all the time. You're not angry at anybody, right? You're just having a good balance, who I am, what I do, I know myself, and I keep things in balance, right? Let's see, maybe a couple more, and then I'll go to the fave experience and hardest challenges, okay? Just some good life tips for you guys in the process of like, how to be. Atomic Habits. You guys know Atomic Habits? Or 7 Habits of Highly Effective People? Love it. Oh, man, I wish I knew all this stuff when I was undergrad. All right, let's go with 7 Habits of Highly Effective People first. Very sad story about the author of this, Stephen Covey. He was so good. He basically changed the work office organization of like how to be effective, and he studied people and he knew, but in his later years he just went out biking, got hit by a car in his neighborhood and died. It was really sad. So he divides up the 7 habits into what is considered a private or an individual journey. These are the things you work within yourself, okay? And then these are the things you interact with the outside world. So these are the things you work within. These are the things you're going to practice and then apply to out here. Which remind me is another thing, Confucius, if I can spell it correctly. Self-discipline, family order, world peace. And I'd like you to work in that sequence. Work on yourself first, okay? All the things that you need to be a master of, master your emotions, master your response, master your discipline, right? And then you can get to working on your immediate circle of family. How do I help those closest and nearest to me? And then I can go out and influence the world, right? I see a lot of people try to distract themselves and stay busy on the community side, but the internal world is not exactly in order, okay? There's a whole lot of mess going on here. We'd like to make sure this is good, and it goes in this way, and it goes in this way, and it lasts. And that's kind of like the idea of a private to a public, okay? being proactive, begin with the end in mind, and shoot. Oh yeah, I love this. Let me expand on that grid. Important, not important. Urgent, not urgent. Okay. A lot of my patients in their 40s and 50s still don't know how to organize their life. Like, what do I tackle first? How do I get all these things done? They see all this to-do list and they just give up. It's too much, right? How to break it down. Things that are important to you, things that are not important. Things that are time sensitive and urgent, and things that are not urgent. Obviously, makes sense to start with this corner, right? Urgent and important. Get it done. Get it done right now. Your bills, right? If you don't pay your bills, you're gonna be behind. You get that credit report. Things happen, right? There's a deadline to it. There's a time, and it's important. Do it. Most of the time, you want to move all the stuff down to important but not urgent. You have your time to work on things that are meaningful and important to you, but you're not under the gun all the time. Procrastinators, right? Don't do that. Where you don't want to spend your time is not important, not urgent. Don't waste your time there, right? And maybe even here, it's like, what's urgent that's not important? I don't know. I can't think of any, but if it happens to fall in there, I still worry about 1, 2, 3, forget 4, okay? So that's what this is. This is like a journey inside of think ahead of time and know that if I am going to be here, I didn't do this, was if I start out here, what does my life look like here? I can't tell. It's way too far in the future, but at least I have an idea, right? I often ask my patients, if your treatment with me was successful, how would your life be different? What would change? How do you see that being different? Help me understand what is a different life for you from where you are now seeking my help. That really narrows it down. I want to be sober. I want to have a relationship with my children again, and I would have a job, and I wouldn't be so strung out, and I would be doing these things for the community. Great. Good. Let's work on those, forming those goals in the way that I'm going to treat you through all the symptoms that you're having, right? Okay. And in here, think win-win. This is with the public, right? It is, how do I do what I do with the strength that I have and you what you have, and so we both get what we want. An example is an orange. I want the orange. Well, you want the orange, and there's only one orange. And there's no way to compromise of cutting the orange. It won't work, right? But the lesson was, why do you want the orange? Oh, you want the juice of the orange. I want the orange because I want all the zest outside. Oh, that was it? Okay, I'll peel all the zest outside. I keep the zest, you keep the juice. We both got what we wanted. It's a simplified analogy, but it is about understanding the human needs of what is it that you really want and what is it that I want, and that can we work it out to that point. He likes less compromise and more win to the end if you can think human psychology of really what is behind the ask, okay? Not, but it is helpful, right? We all know what this first one is? STFU. It is good to start with that so that you can seek first to understand, right? Don't be so attached to your ego. Don't be so about proving everyone your point, right? And attached to that, I must be right. Usually people in that space aren't very happy. They're always fighting. They're always creating a space and a gap because, can I help understand what you're going through? Or help me understand what it is that we're trying to work on here. Just those simple words. It just opens up a door for a person to want to engage and build with you rather than, talk to the hand, right? And then this is synergize. Another form of win-win, in my opinion, like what are your strengths? What are my strengths? How do we align to do a super awesome job, okay? And once you get all these 6 habits down, he says, sharpen the saw. Imagine like this is a saw, okay? And that you're gonna keep on working and continue all this in different aspects, different realm. Imagine being a medical student and having all this under your belt, and coming in to deal with a difficult part of your life right here. This will carry you far, okay? These simple life skills like this. All right. Day in a life. So I guess, I don't know if that's helpful because it's so different for everyone, but for a psychiatrist, it depends on what you work in. If you work in an outpatient setting, it's pretty set in stone. You just got 8 patients a day, see them, go home, right? And your patients are different in the types of problems they have. Inpatient is a little more fun because now you deal with a team. right? So the patient was admitted last night. First round, the crack goes to this resident team to try and get the story together. And then the residents present to the attending of what happened last night for how the patient got into the hospital and why the patient is here. And the team comes up with a treatment plan together. And then the residents go around and see all the other patients that have been admitted over the last days, weeks, months, and then come up with a plan on how do we package up this case for discharge. Do we send this person home? Do we send this person to a higher level of care? Or do we keep the patient here? So there's a lot of critical thinking in the meds, in the life choices of the social worker, working together, finding housing, that kind of stuff. So even though it's not scientific, but it is critical, right? You have to hear their story of like, well, he wants to go home, but his money is being tied up to a person that controls the spending, and only if the person can release the funds, then they can get into an apartment. So all these little life details just comes out. So you're really learning to figure out life details for the person. And maybe how I tie that in, what I do outside of work. A lot of friends ask, I don't know if this makes sense. A lot of friends ask, how do I not take all these heavy stories home, right? You hear depression, you hear anxiety, you hear suicide all day long. How do you not bring it home? I think for me, it's about having purpose and like a lot more, I don't know, I think my job is easy. I think going home is when it gets really busy. I got to shuffle 4 kids, right? I like cooking, so I do the cooking, and that means dinner. And then, I like having friends over so that, we can talk, so that we can talk about other things. I like doing this because it's not, like just go work, go home, go work, go home. I want people to learn and have this kind of like rewarding experience of having a positive impact for people, right? So to me, it's like what motivates me, what makes me feel like I have more energy as I do it. It's like, you only have 24 hours a day. How are you doing like cooking, kids, camping? Oh, by the way, I do camping. I have a trailer. Those Airstreams, the silver ones that we tow around? I love doing that, going to the national parks. My kids have seen over 34 national parks, right? We just drive around everywhere just to see Alaska. I love Alaska. I went up there. It was amazing. So went on a whale watching, and that day we saw orcas to the right and then gray whales to the left, and then, it was just crazy. It was just like eagles, bears, everything. It was just amazing. Love it. So find what it is that resonates with bringing you joy and make sure that stays in you, right? Depression has these things: sleep, interest, guilt, or self-esteem, energy, concentration, appetite, psychomotor, and suicide ideation. So how do we know a person is depressed from a clinical standpoint? Not just sad. I mean, sad is allowed, right? There are normal ranges of human emotions to have. It's some people who no longer able to feel and just kind of like are blah like this, who say, I would do anything to actually have an emotional range to things again, right? It's okay to feel sad appropriately. It's okay to feel happy, anxious, anger, and all irritability, aggression in the right context of things. Those are signals to your body of why it's not working for you. And your job is to figure out, why is this triggering to me in my own history of my psyche. But from a context of life, when these symptoms start to impact you where you're not functioning, right? It's a disorder, major depressive disorder, bipolar disorder, post-traumatic stress disorder. The disorder of things that are no longer functional. You're not socially functioning, you're not occupationally functioning, and you're physically not functioning. You're just like suboptimal, right? Sleeping, some people sleep more, just want to stay in bed. Some people sleep less. That hamster keeps spinning, can't sleep, keep staying up, worry, right? Interest, down, withdrawn. Things that used to bring me joy, this is why I went tangent here. Things that bring you joy are now down, like no longer interested in doing things, no longer feeling the joy of video games, hanging out with friends, playing the guitar, going camping, blah. I just don't want to do anything. Just isolate, blanket overhead, and, escape. A lot of guilt, a lot of low self-esteem, sense of worthlessness. It's just the person feels like I'm a burden to my family. I'm not of worth. I am not of significance, and I don't bring any value to whatever, right? And it's just like negative talk, right? Energy, like 10%, 5% battery, concentration down, can't focus. A lot of people mistaken this concentration as ADHD. I'm like, wait, no, you have difference. There's a difficulty in focus because it's all these other things going on, weighing heavy on your brain. It's not because you have ADHD. So know the context of the diagnoses first. Okay, appetite, some people overeat, some people undereat. Depends on your childhood experience. Some people may have a very stressful childhood related to food and how their parents were like, finish your food or you're going to be punished. Now food is negatively associated. And so whenever they feel something negative, they associate that with like, let me restrict myself from eating. Not uncommon to have an eating disorder later on because of that childhood experience. Or some people eat to cope, right? Just eat to feel, eat to feel, eat to feel, kind of like, soothe in a way. Psychomotor, brain, body. What your brain is feeling, your body is experiencing. Heaviness, just tiredness. Or like, sometimes they say like, it's like I'm wearing lead in my boots and it's like I can't even move. It's this heaviness, okay? Or the fidgeting or the anxiety or just the sense of like restlessness in a way. Your body's feeling all that. And of course, the suicide ideation. That's, if you ask me that what's a hard day, when you feel like you're doing your best and you've given all that you can, and your whole entire team feels the same. You're not just like, dismissing a person's pain or whatever. And the whole team is surprised that this individual who has gotten everything that could have been given still finds that ending one's life is the preferred choice, right? It makes you doubt yourself sometimes. Did I miss something? Did I do something wrong? Did I say something that kind of triggered him to do that? And the questions just keep staying in your head, right? And to reconcile with that and to make peace and know that you and your team did everything you could, and you can't save 100% of everyone with this. It's in psychiatry, they taught me this, and it sucked that it was true, right? It's not a matter of if you will lose a patient to suicide, it's a when. I was fortunate to have at least 3-4 years into my career before I learned about patients, taking their lives. Most of the time, it's after I had the treatment window with them. It's like later on, I find out from some other one else reporting back. But I have had one actively being in my care, about 2 or 3, that still chose to do it. That was tough. And then, you're human. You're supposed to be hurting when something like that happens. Surgeons losing their patients in complicated surgeries, right? In just any field, especially palliative care. Does anyone know palliative care? It's like caring for end of life with a lot of passion and compassion and pain relief. It's just painful to see a person dying and to do your best in easing their transition. And it hurts. Oncology, that's a painful one, right? You're always talking about how can I ease your pain and how many days, weeks, months you have left. It's constantly that kind of conversation, right? And even more important to have that work-life balance. So I say doctors who work long enough will remember difficult stories of how they lost certain patients. Favorite experience, that's easy. Like any day that you win in changing a life, that's like, yeah, and you never know how it comes about. Sometimes it's a conversation on an airplane next to a person. Sometimes it's, with your patient who in the ER. I love this, that I enjoy going into an ER. Not that I enjoy, but I find it rewarding after it happens is I go into the ER. Why are you here? I want to end my life. Why? X, Y, Z reasons, right? And I'm sitting there and I'm just talking. Tell me about your life. Tell me how I got here. And why are you here instead of dead already, right? So you ask these really, like, I can't go up to you and ask you that, right? But in the doctor-patient relationship, in that moment of crisis, you're authorized and you can cut through all that shortcut and ask those questions. And doing all this stuff that I do and talking, giving them a sense of hope, that future-orientedness, a way to think that there is still purpose, meaning, and reason to live, and that they're saying, thank you, doctor. Yes, I agree to go into the hospital. Please keep me for a few days to stabilize my life, and thank you for finding me a solution to the problem I did not think was possible, right? And to do that in a 30-minute time span, that someone could have ended their life, and you just talked for 30 minutes, and you changed their whole life around, that is very empowering. That is rewarding. That is like, even just one life changed is one life saved, right? You don't need to do like big scale anything. That to me, going home, giving me chills, you know? It's like I saved the person, right? I didn't have to do CPR or anything, but nonetheless, you saved a person, right? And you can save it from the inside, the inception, that's saving the person for life. Once they have that sense that I have purpose, meaning, and that someone had changed me and given me that thought, and I have worth, that's worth it, okay? Let's talk about specific characters in journey and growth. Strength of character. Point of view. So just what helps to go through the hardship of medical school? What helps to go through all the life challenges in general? Okay. Think about bamboo. Soft, flexible, bends with the wind, but hard to break, right? And being that kind of like the ability to withstand and still stand up and take the next step in your journey. Having a point of view of another person's perspective back to you so that you're not just stuck in your own head of like, all that matters is my ego and my perspective. Having the adapt and overcome kind of thinking, adaptability. Yes, it's shitty. Yes, life isn't fair. Yes, it's not the best optimal condition that I want. But what can I do at this point to adapt and overcome this, right? Military loves teaching you that, right? Work what you have and make do and still survive because no one's coming to get you. You better survive until they do, right? Flexibility. In these type of, hierarchy and training, the ones who are miserables are usually the ones who are least flexible, right? There's some fun doctor Facebook groups and whatnot, and you can see all the doctors writing their rants on there. Oh, I hate medicine. Oh, I hate this and that. And that. It's all the ones that are too rigid and inflexible, and they just thought their view is the only view, and then they can't shake it, right? Even full-grown, 20, 30 years into practice, and yet can't be flexible. Humor, that's pretty good, okay? It's just to keep things light, know how to use it, right time, right place. That helps a lot. So, Any questions? I'm going to pause for a little bit before I go into the diagnostics a little more. Yes. Do I have a therapist? In third year of residency, they make you go have one. You do it so that you would know what it's like to pour your story out, wait for a week, come back and tell your story again, reflect on what happened during the week, and see the psychodynamic patterns of how am I bringing my life into the relationship with the therapist and somehow repeating the same pattern with the therapist for the therapist to catch and tell me, did you just see what you did, that you just did out there and you're doing it in here with me in here? Really? Even me studying psychiatry and I missed that? Beautiful, right? We catch patterns, we catch sort of like life interactions and circumstances that we're kind of blind to, right? You're not expected to know everything. And people think like you got to be all self-composed because you know all there is to know about psychiatry, mental health, emotion, regulation, and everything. No, if my kids irritate me, I'm not going to be very good at controlling myself at times. I'm going to just, whoa, please help me, right? Knowing yourself is very key. Knowing the range of your capability, and there's no shame in asking for help. They do a lot of what's called supervision. When I treat all my patients, and all my patients get the same treatment from me, no more, no less. But somehow, one of the patients I'm starting to give a lot more attention to, positive attention to. Ooh, I like this patient. I'm going to be extra nice. I'm going to give a little more time. I'm going to talk nicer. I'm going to talk a little more personal stuff. Boundaries, right? Learn to know that, I'm doing something different. I'm having positive feelings for this person. I better talk to my supervisor, okay? It's not bad. You're human. You're gonna feel things for people. But knowing when you do and doing something about it so that you preserve your role as the doctor is key. And it goes for the patients you don't like either. Same. There are some patients that will just not resonate with who you are and will make you really upset when you're just about to see them. You dread it because they believe in killing children and you still have to see them as a patient. How are you going to do that? You know? They actually hurt people before. If I don't like that, how am I going to deal with that? How do I treat this guy so he doesn't hurt anyone else? Or how do I treat and contain him because he's in jail? I still got to treat him and doing all that other stuff so that, he still finds meaning, purpose, and whatever else in his life, in this point in his life. Very hard, right? Know that about you. I like to work in military because I can deal with it this way, right? Some people like, maternal mental health because they like dealing with, moms in their kind of like growth and life stages, right? And so just know what your strengths are, know where your vulnerabilities are, know when to ask for help, right? Good question. You do need that. My wife's a psychiatrist as well, so I often joke she's my doctor. So I saw a hand back there. Was there a hand back there? No? Okay. I thought, yeah. You had your hand up first. Yeah. Did you have your hand up? Yeah.
Why did you go into the military?
Personal choice. I felt like I got an opportunity to be in America, and there was my way of saying thank you to serve. I did not have a clue. Again, did not have a clue what it would involve. I just said, let's go join, right? And I joined in medicine, joined during medical school in Missouri. And I joined in 99, and then 2001 happens, 9/11. That was when the whole military operation, I think you guys are all born after 2001, yes. Yeah, so 9/11 happened, and all the doctors in America were deployed to combat. And so me in training right at 2003, 2004, usually you get to go right through residency, but then at that time they needed more doctors deployed. So I was on a ship with 3,000 Marines. And because I had my master's degree right after undergrad, I was more senior in academic stature than my peers. So they promoted me up to be the lead doctor. Not like I knew anymore, but I just happened to have a master's before my peers did. So they put me in charge of 5 doctors, 3,500 Marines across 5 ships, going into daily meetings with admirals and generals to decide which way we should go because this patient is now ill. That's pretty cool for a 20-something-year-old to do, to learn leadership in a hurry. So, good question. What do you guys think? How do you gain a patient's trust to open up? That would be oversharing. You're the doctor in psychiatry. You want to keep some professional boundary. But you can use in the right context to build that rapport.
I think it's like also the way you kind of present yourself as a person to the patient.
You are the tool. You are the tool. Before any kind of psychiatric application of therapy, you are the tool, right? How does a person feel when you enter the room, talk to them? In a normal interaction, it is one of the most important thing is non-judgment, right? Why do people so fear going into talking to a doctor? It's all the shame, all the guilt, all the I've never said anything to anybody about this, right? Whether it's like personal pain or even more painful, a childhood history of abuse. It's not easy to get that part of you to say that to anyone, right? And so being present, being non-judgmental, and being receptive to what the person is willing to share is usually the first step to being helpful in establishing rapport, in establishing trust and confidence of the person to tell you. It feels so good. It's like, I keep hearing it and it brings a smile to my face every time it happens, but patients will often say You're the first person I've ever told that to. And they're like 60-year-old, right? It's like, wow, you waited this long? What? Why? Right? But it's lovely when you hear, because that's like a person has finally felt safe, psychological safety. They felt safe to say that out loud. And that's half the battle, to be able to verbalize a repressed pain. It's not fun when they bring it up, because then afterward they're gonna hurt, and you gotta know how to help them through the subsequent sessions. But to even bring it up in the first place, to allow for this to come into space and to recognize its existence is a huge win to getting that person toward, a new direction. Your brain just plays this game of just rethinking the same thing unless you do something different to break it out and do something different, right? So Atomic Habits is that, right? You got to build and stack and do something different, and you got to make it to stick. Same with erasing a habit, right? Parents come to me asking all the time, it's like, my kid is on the screen all the time, right? It's like, well, how are you building that into your day? What are we doing? The kid comes home, homework, physical exercise, and chores, and screen as a reward. But how do you do it in the sequence so that the child values all the other aspects rather than just, I'm on my screen, thank you, bye, right? So building in all those components for all the way from childhood of life. I love drawing this timeline. Whenever I do a psychiatric interview, the H&P, I like to break it up. It's like, tell me about your childhood. What do you remember that was good? What do you remember that wasn't so good? Tell me about your adolescence, right? How'd you do in school? Friends, struggles, bullied, that kind of stuff. College years, right? What's going well, what's not, And where you are now is likely some kind of life struggles right here by the time they come to my office. Something's not going well, right? Whether it's like don't want to live anymore, or I want to, but all these things are getting in the way, right? And how do we strategize to get that in a direction that is aligned with the person's hopes, wishes, and dreams, right? Let's see. This is important. This comes in a lot. Might as well learn this. Addiction, okay? College age, where it begins, a lot. Fraternities, socially accepted, just a lot of like partying. Everyone drinks, everyone drugs, everyone does all these stuff to just like tweak the brain a little more. And if you have biological predisposition because your family has dependency, you're likely to have that same gene being at risk for developing dependency and addiction. Be very careful, right? Children of, I guess they did a study of sons of dads who have it. The odds are stacked against them. They just got to fight really hard to not be stuck in that addiction, okay? So what does addiction look like, and what are the criterias? Tolerance, withdrawal, overuse, difficulty with quitting, spending all your day in activity thinking about the next drink, negative health consequences, and social consequences that are also negative. That's like negative health consequences is like, your brain, your liver, your kidney, to say a few, right? Social consequences is like job, marriage, money, legal, DUIs, and all that stuff. Despite all this stuff going down the drain, life not going well, person still struggles with staying sober, still chooses to drink, still chooses to drug, right? The more you drink to get that same buzz. First time it was one drink, now you gotta drink 5 drinks. You gotta take 5 Xanax, 10 Adderalls, whatever, to get that effect, right? Withdrawal. A person who has drank for a long time and now on, abrupt withdrawal, they can develop seizures. They can develop vital signs, instability, right? Overuse. I'm just gonna have one drink. Nope, 1 turns into 2, 2 turns into 10, 10 turns into forget it, I'll just get hammered. Difficulty quitting. Anyone seen the movie Flight from Denzel Washington? It's a good movie about a pilot who struggled with alcohol and other substances, and he was compelled by the court to stop it, so for him to continue with his pilot license. And there's a good scene of him emptying his whole house. He's got all the alcohol gone. He's being a good boy, doing a good job. But he was triggered and he relapsed heavily, right? So difficulty with quitting, even though the resolve in there, but it's something that you have to be aware of and work really hard against. Activity, this is kind of like a person who wants to hide their drinking and work really hard to kind of like, think about the next drink. When am I going to do it? How am I going to do it so that I conceal it and then no one knows about it and then I still can continue my habit? And then negative health, social consequences. Only need three out of these 7 to be clinically, diagnostically positive for substance addiction, okay? So these 2 alone can be the 90% of the types of most common diagnoses you see. You'll see bipolars, you'll see schizophrenia, you'll see marital problems and, all kinds of other stuff, but the bread and butter of psychiatry, you'll see these 2 a lot, at least in my world, okay? Let me pause there. 6:30, questions, more of something I didn't go over you want to hear more of. I guess it's just overly worried about something that hasn't happened yet, or worry that it will happen and you can't escape it, right? The healthy way to treat it is CBT, which is cognitive behavioral therapy of thoughts, feelings, and behavior, right? How you think, how you feel, and how it influences your behavior. You learn to catch it, check it, change it in therapy. In anxiety, the danger way of treating it is to get a benzo, Ativan, Xanax, Klonopin. It helps right away. It's basically alcohol in a pill. It just, it's gone, right? But that habituates your brain to want more of that to escape rather than using the CBT of catch it, check it, change it. I don't want to use the cognitive power to change myself. I just want the pill to just take all my worry away. But you do that, you end up being tolerant to it, and you're going to be dependent on it, right? One of the difficulties in treating military personnel early on after they came back from the war was they all looked like they had panic attacks. It was like, fireworks go off, mortar rounds, right? Or a muffler going off, someone just fired a bomb, or a trash bag on the road. That looks like an IED, right? So their senses is reading all the cues in a threatening way, and they panic, like true panic. And doctors back then, with the best of intention, gave them all the benzos to help. But what ended up happening over time was they became dependent on the benzos and did none of the therapy to process the trauma, which is what works in the long run, right? So anxiety, SSRIs, which are like Prozac, Zoloft, Celexa, Lexapro, Effexor, all those SSRIs are good to help with anxiety. Why? Because your brain has like all the serotonin sitting in there, and when things happen and you use it all up, you have less of it. And so the SSRIs help to retain this concentration in there so that it just biologically helps with maintaining the ability to resolve problems and to withstand the stressors. And so things that are usually stressful and anxiety provoking are less so. All right. Finances, gosh, immigrant family, right? I don't have much. I just got a loan. I got a loan and I joined the military, which helped to pay some of that loan. And I worked in the VA that at the time had a loan repayment incentive program. So if you pay your student loans for 10 years out of the 30 years that you owe the loan, they will forgive the other 20 years, but you got to pay all the 10 years. And I did. So the rest of it's gone. So, however you want to get there, there are programs out there. Don't worry, you'll find a way. Like if you're business minded, I would highly encourage, or even if you're not business minded, but you have the bandwidth to do it, I would highly encourage doing some kind of business training along with your doctor program. Why? They don't teach doctors to be businessmen. They teach doctors to be bad businessmen. You're just worried about your patients all day. You don't know how to worry about the finance of your life, right? And though the successful doctors have a good balance of those things. So resume tips, gosh, I think I'm way too old out of that realm to give you anything, but I think genuine and authenticity of telling your story and how it connects you to people is always important, right? If you have a 1-minute speech, right, we call it the elevator speech, you got the 1 minute, from one floor to another, what are the best things you can tell about yourself so this person remembers you, right? They walked out and said, yeah, Kathy, you really left an impression there on that elevator talking to me about your summer project in Africa, right? Something like that. Research, I just got lucky. I made enough connections that I had friends in the right departments that just got me into the program and, I don't know, build more connections. What can I say? Any other questions? I don't want to end it early if you guys have time. Yeah. Yes?
This is about the H&P. Like, I'm in a clinical assessment.
Uh-huh. Okay.
Or like clinical psychologist.
Uh-huh.
But I was wondering, do you use like ABC stamp looker?
ABC what?
Stamp looker. It's
Oh,
appearance,
tell me more.
behavior,
Uh-huh.
cooperation, all that.
I leave that to my psychologist friends. Yeah. I do like, gosh, I mean, when you first talk to a person, I don't go straight into like diagnostic criteria. My style is just ask basic life questions, right? Tell me your, where are you living right now and your relationship status and your financial status, your occupational status, your legal status. Just talk. It was like, hey, John, how are you doing? What brings you in? What's your current living situation like? Where are you living at? And who are your primary support? And how do you make a living? How do you survive each day? And tell me about your work, right? And do you have any pending legal stuff? It's soft enough. It's just getting to know. But the way the person answers, the way that they say certain things, you can tell. You can tell, like, if this is a person who is externalizing all their problems and that everyone else is the cause of my pain and suffering, or it's a person that's like truly hurting, doing their best to try and get the help, but they just can't catch a break. And, there's people that are very, manipulative. They are better at reading you than you reading them, and they will play games with you. And you got to know that, how am I going to work this through? They'll ask you for all kinds of stuff, and you got to know how to set a limit to say, no, thank you, we're not doing it that way. So the style to the H&P is to kind of like the non-judgment and easy conversational, just build conversation, and then you get into, past psych history and social history, like childhood, school, family, jobs, and whatnot, and then past medical history, because sometimes medical conditions can have an influence on psychiatric conditions, family history, substance use history, right? And then your physical exam, and you review your labs, because some conditions you do have labs influencing it, like hyperthyroidism can influence your mood, your appetite, the way you are thinking about things, right? And for females, your hormone levels during different stages of your life, right? And then we go into past diagnostic tests, and then you can also do whatnot, and then you form your working diagnosis, your assessment of what you think you can do, and then your treatment recommendation. It's just one whole story. Psychiatry is one of the longest notes to write. It's just because you're taking so much history. It's not like a surgeon's note. It's just like walking, well, gone, bye, right? There's a lot to it, but I enjoy it. It gets to know the person. The longer you do it, the more you can do it in a shorter amount of time, just to get straight to what the person's needing, what they're really asking behind it. The average time I spend with dealing with the patients? Oh, gosh. It could be, let's see how what I hear you're saying is how long it takes to maybe treat these people? Okay. Depends. Some people are lucky where you have a finite problem and it's just like, no other risk factors. And it's just like first time coming to your office saying like, I meet all these criterias, let's try a low dose, antidepressant, and then couple it with some therapy, and 6 months to a year later, they're good. Oftentimes people ask, how long do I need to stay on the psych meds, right? They always want to get off of it. Or they feel good from the psych meds, like, oh, it's doing what it needs to do, I'm no depressed anymore. They go off the psych meds and they're right back to where they started from, right? The neurotransmitter imbalance is real. If we have already brought it into balance, maintain it, right? And how long do I need to maintain it for? My rough estimation is at least 6 months to a year of being well. Why? In that year of being well, are you going to school? Are you doing your job? Are you having a good life? Are you not having thoughts of hurting yourself, right? All these things are in the positive trajectory, then you can come back and say, doc, I'm doing pretty well. Can we lower the dose or change the dose or not take the dose because I got to figure it out? Good, let's try it. And you tell me if it's going okay or not, right? So there is a flexible endpoint to it if other things in its place are working. Substance use is risky because a person can have multiple times in their lifetime of relapses. And that's the most challenging part for me. I think it's extra hard for me because I didn't want to go into substance use treatment, but the PTSD treatment is so comorbid with the substance use. You just got to know it, right? They cope because that's what's accepted in the military. Everyone drinks in the military. They drink to celebrate, they drink to grieve, they drink when they're stressed, and they drink when they're angry, they drink to sleep, right? Everything is involving around like, get a drink. And it becomes problematic without even people knowing it, right? And then it becomes the thing that they don't know what else to do. They have a hard time staying sober. It's easier to just drown yourself and suppress it all. And so the answer is it has its cyclical pattern. Some people can have an early break and be done with and never have to worry about it again. And some people have to work really hard being in all these kinds of sobriety programs to continue to stay sober and being a mentor to someone else and being, having a mentor to them or a sponsor so that they stay sober. They have to be held to a higher accountability. Guys in my program, because I'm doing drug tests and I'm always keeping them busy, they'll have less likelihood of relapsing, but it doesn't mean 0%. They still do. But when they do, when I was in the military program, we had a pretty strict policy. We just kick you out. You're done with treatment. Go back to your boss. Let your boss deal with you. He'll probably kick you out of the military. But we may be flexible in saying you did not have a good option to get well at the time, and we're going to give you another opportunity. They do well. They stay well. Good. Congratulations. Sometimes they relapse, and then we give them another treatment, right? All this is still fairly, I think you guys are right about here. And then when you get enough of these years in you and you see all the people exposed in the world to that, I think how this applies makes more sense. It didn't to me until, the last 10, 20 years of my work in just seeing people doing their best and they still struggle and doing their best. And then they go through a few cycles before they really are like, I'm fine now, I'm doing well, and I'm being productive, effective, and meaningful in the life I have with people around me. Yes.
How do you deal with patients that are like you mentioned, some people are forced to go see a therapist or a psychiatrist? How do you deal with those that evade their feelings and when you're checking up on them, they kind of lie about their progress or fabricate what they tell you about, because you're not really seeing those patients in their actual lives. You're just seeing them in your space, and
Exactly.
you're only seeing what they're giving you. How do you deal with getting around those obstacles?
Good question. No one is going to they're not going to be all figured out in one visit, right? And you'll have multiple visits. You get collateral, right? Family report, coworker report. And in the treatment I have, I'm pretty lucky because they're my captive audience. They live in the building for 6 months. I have 24-hour nurses so that they observe their behavior when they are with their peers, when they go out on outside activities, when they are in the classroom, when they are in one-on-one appointments with my psychologist, with my chaplain, with my medical doctor. So they give this comprehensive observational stuff, and people can't hold on to the fakeness for too long. You will be able to see who they are sooner or later to kind of say, can we have this talk? We noticed this pattern about your lack of engagement in care, and we're concerned about the direction that it's going, and we'd like to make sure that you're staying on track. How can we help you with that, right? Most of the time they hear that as a concern and they'll work with you. The manipulation and the degree of fakeness, it's there. And I will say on the note, I'm not sure about the patient's authenticity and genuine effort in this treatment. Perhaps it's motivated by court compelling this person to be here and to do it as a checklist, but out of their own motivation and intention to get better remains to be clarified and Hopefully with more time and clinical observation, we'll have a better picture. It's okay to write that. You're not expected to have the perfect answer all the time in your note at all times. You're okay to have guesses as to what is going on. And you can say, this word is very labeling, and it could really hurt a person when you read the chart. But if it's true, you got to let your other clinicians know. Like, a person's malingering, right? Malingering is intentionally lying for the self-benefit, right? I want that handicap plaque. I want that benefit. I want all these things. I want. I will lie, cheat, and steal and report false information so that I could get it. I'm malingering, right? That's no good. And you can say that in your note. I question the patient's true motivation here, and unsure of their, ability to remain truly in treatment, and seems to be hyper-focused on the benefits of their, kind of like seeking the benefits of their status more than actually getting the positive treatment goals kind of deal. It's okay to say that. I've had a lot of people lie to me, and that's hard. Patients who have had used and drank and positive on their urine toxins, and yet they sit there in front of you, and I ask them, is there anything you want to tell me about, your weekend activity? No, nothing. Was there anything that you did that was out of the ordinary? No, nothing. Was there anything that could have maybe be in your system that you'd like to tell me? No, what are you talking about? Well, the urine tox here shows that there's alcohol and, cocaine in your system. Really? How did it get there? No way, that's not me. You guys must messed up. That must be the lab's fault. And you got to have that conversation, right? And then you're like, well, here is this and that, and here's a lab, that shows that not only did you drink in the last 4 days, it stayed in your system long enough that it shows that you've been drinking the last 4 weeks, right? And I'm not sure how we want to do this. You're here for treatment, right? Is that, what did you talk about when you first started the treatment with me? I want to be sober. I want to be with my family, right? And help me understand, how is that in alignment with what happened? Sometimes it takes a lot of those ways of talking, and they'll come out and say, fine, you got me. I was afraid to be kicked out of the program, and I just thought I didn't have to say it until you catch me. And they'll do that repeatedly in their personal lives. And that's how they got to the place of where they are, because they just kept breaking the trust, and no one was able to be there anymore. And it's pretty difficult to come back and remain supportive, trusting, non-judging, and helping. It takes a lot to come back to that. Sometimes I have to let patients go. I'm saying, I'd like you to prioritize your substance use treatment for now. I'd like you to get at least 30 days sober. I'd like you to remain in sobriety. And then when you feel good and ready to work on the therapy side of things, come on back. We'll take you in, all right? It's okay. You're going to have to own up to the consequences of your actions. And sometimes the best redemption stories are the second round of admission. They do amazing. They learned their lesson. It's like, thank you for the second chance. I can't believe it. I'm here. I'm going to do everything I can. And now this time I'm doing it because I want to, not because the court tells me to. That's when change took place. I'm thinking in my head of the people I've seen that has had similar childhood experience and had different trajectories, right? One who is a very capable, competent, caring clinician, even though had a childhood history of being, SA'd, right? And then one, more commonly, just continues to struggle. This is the sad part. This is why it's so important to protect against the risk of SA in the least expected circumstance, but it happens all the time. It's with the people you know, it's in the context of when you least expect, and all these things that are surrounding that makes for the right circumstance for the person to not realize they are in a very predatory, threatening environment. And these unfortunate souls do have a much difficult time. It's not unhelpable, but manage your expectation of how much you're going to help. The person's self-worth in physical intimacy, the person's self-worth in feeling validated, the person's self-worth in being of value outside of their physical availability, all those things, it's a mess. And you got to, know and be the the big container to hold all that for them. Trauma work in those scenario can help. Some people don't realize they hold all these childhood traumas until something similar later in life that triggers it. They have managed to suppress for like decades, and boom, it comes out, and then it's just totally disarray, and then you got to work through the process. And military men, of all things, are actually high numbers of being essayed earlier in life that we have no idea about until we sit and do the whole history and saying like, what was your childhood like? You know, any traumatic memories, and when you build enough rapport, they'll be able to tell you, and that's when you got to dig down and start doing the work. The childhood trauma primes you for being vulnerable to the adult trauma stuff. So someone who has had adverse childhood events, ACE, living in a high crime area, low social economic status class, and all kinds of gang stuff is just rough life, right? You grow up surviving in the blueprint that I got to be aggressive to survive. It works for me. And then you get to here, you still do that, but then something happens in the combat sense, and it triggers all this stuff back in childhood again. And it's just, you got to work through here, and then the person can work on this here. There's not like a sequence of things. Sometimes you got to, do this and then do that, or do that and then do this. It just depends on the psychodynamic context. That's the fun part. If you don't want to go into psychiatry, you can go to psychology. It's a lot. It's like talk all the time. Just figure out patterns of people. Figure out patterns of people. Why are they hurting? What are they needing? And how do we catch it, check it, change it? And the context of like how all this childhood stuff manifests here, and how do we do what we can to kind of like still bring hope, meaning and purpose and all that. Hope, meaning and purpose, hope, meaning and purpose, like it goes further when a person has the motivation and seeing the worth in themselves. Yeah. Did I convert anyone to go in mental health? It's a fun field. Nowadays, even if you are starting your, let's say, first year of medical school, that takes 8 years. 8 years later, I believe this field is still in very much need. As when I finished this, mental health used to be very, like, not a popular field. People liked everything else but mental health. It just was seen as like, too much work kind of deal when you have to listen to the whole story. But now it's like one of the most sought after residency, because they know the demand and the joy and the reward of doing this work. I love it. Imagine I can't stand in the OR with my lead jacket on doing surgery at 70, but I can sit in a chair and listen, and I think I would be better as a listener in my 70s than in my 40s and 50s. And it's not hard work. I can sit and listen and just offer my experience, and it'll go a long way. One of my mentor is a clinical hypnotist. Smoking cessation, fear of flying, weight loss, amazing. You would never know from just doing hypnosis and doing EMDR, So it's a very fun field. I encourage it, and good luck to all you guys going into it. Nice having you here. Thank you for your attention. Take a bunch, so. I'm not covering you, am I?